Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
Hi. My sister said something funny the other day. She said he always says hi after he introduces himself. Whereas in America, Americans tend to lead with a salutation. And she said, but Marcus, she works at a company called Neutral. And she said, Marcus is British and he's the same. He'd always be like, Kavita, it's Marcus, hi. And she just put it together.
I've never picked that up as being a sort of actual difference. Feels natural, right? It's probably the BBC in this country because that's how we learn. How
to pick up the phone. Okay, well, we were going to talk another long-term study. We've now talked a couple of these. CombiAD officially was 10 years, wasn't it?
Yeah.
Although the curves sort of don't go out to 120, they go out to 80 something, but I think it is 10-year data. Of course, Checkmate 067. And now we're going to talk Keynote 006 10-year data. So that'll be nice to see that. But before we talk about that study, let's just do some quick fire questions. James, do you snore? Do you know if you're a snorer?
Yeah, at times, but everyone's a snorer, aren't they? I mean, I dare anyone to say they never snore, but you can't, validate this yourself anyway by definition, can you? Someone else needs to tell you, or you would need to video yourself or something. Yeah.
Yeah, you could record. There are these apps that you can do, because I just spent the weekend with my sister and we shared a bed in a hotel room. I guess that part's not necessary to say that we shared a bed, but I forgot to book 2 separate beds. And so we just were in a king size together. And so those couple of nights, neither one of us snored. And we have parents that are both really strong trains crossing, I think you told a great story of a colleague and you'd have to get a different room, being even in the bathroom of a hotel room would not be enough, not with my parents, and my grandmother was the same. So it's a real fear, but neither one of us were snorers. Now, I think if you have a heavy night of drinking or positional, whatever, you can do it.
Yeah.
I bought a cool mattress here that's very adjustable, and it does Trendelenburg, it does zero gravity, but it also has a snore function, an anti-snore function. So I don't need to use it.
What happens when you press the anti-snore button?
I think it raises the head a little bit.
And it senses that it doesn't sense when you stop snoring. It's not responsive. No, it just does it.
No, it's not AI. It's not robotics. So somebody would have to do it to be like, oh, that person is snoring, and then it would raise that, and then you could lower it. But do you have a side of the bed that you prefer?
Yeah, almost always left. But I get given instructions on this. So yeah. My preference is, so I almost always. So now, if you're looking at the bed from the foot of the bed, it would be the right. But if you're at the head of the bed, looking downwards, as it were, it would be left. So yeah, I guess that I don't know why.
I couldn't think of the right word for this. I certainly don't want to use the word promiscuous. I have zero preference on this. But also, I sleep alone in my bed, so I sleep like a starfish. I just sort of sleep in the middle like a starfish, all my limbs out. And then when I check into a hotel room, it's either side. It just sort of depends. Usually, it's the side farthest away from the bathroom because that's usually a window side. Anyway, so I can,
So I think hotel rooms, it's all about the layout, isn't it? If you see what I mean, and the noise.
Oh, you don't go directly. You don't go directly to your side in a hotel room.
No. I would sort of check out the room, if you see what I mean, and usually it will be how noisy is it, how light is it, how can I maximally get away from all that sort of stuff, rather than me having a particular sort of preference. What's the best way to get to the bathroom?
Without knowing the terrain as well as you normally, There's a superstition.
That's the thing, right?
No, of course. There was actually a hotel room I stayed here in Colorado that I really liked, because as soon as you would sort of stumble and hit, there was some sensor that would turn on like an underbed light, and then as soon as you got into the bathroom, you didn't have to hit the switch. The light under the vanity would light up. So it was just so lovely. And then it was very short-lived. It was short-lived enough that if you're on the toilet long enough, you'd have to sort of like wobble to get it to turn
Start
back on. But
starfishing on the toilet.
start There is some funny superstition in I don't know if it's in Hindu tradition or Gujarati or what, but my mom used to really not like it when I was little and I would get into bed with her or chat with her in bed. I switch my position. So if she's got her head at the head of the bed, obviously at the pillow, I'm the opposite. So I've got my feet up to her and my head is at the base of the bed, just so we can talk easier, you know? I do this on the beach. I do this a lot of places. And she would always say, no, 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 no. That's bad. You have to, like, we need to all be facing the same direction. And I said, why? And I vaguely remember her answer was something really strange, like, because that's the position you're in when you're in the coffin, you're reversed. I mean, now as an adult, that makes absolutely no sense to me. And what does she know about coffins? Because Indians are essentially cremated. Anyway, so she didn't like it if I reversed it, but now almost out of like a slight defiance. Also because nothing has happened, because I've done it my whole life and nothing bad has happened.
Yeah, I mean that's just superstition, isn't it? It reminds me of fishing superstitions. You know, I used to fish a lot, and you know, fishermen. I don't know if it's still as superstitious as this, but certainly here they would never get onto the boat on the left side. You would always have to get onto the boat on the right side. So the starboard side as you're facing forwards. And so literally people would never, ever do that. It was regarded as bad luck. And taking anything green to sea is also regarded. So literally, if you like had you sort of a bag with your lunch in or something like that, and it was a green bag, some people would actually refuse to get in the boat with you unless you didn't take the bag with you.
Wow.
Very, very superstitious. But I mean, I think that probably speaks to, you know, the history of fishing being sea fishing being so dangerous and so sort of on the edge, if you see what I mean. And, you know, routinely a lot of people would die in storms and stuff like that, you know, then suddenly the people develop all these habits. Oh, this is good luck, you know, good omen, all that sort of stuff. But yeah, very, very strong. Well, it was when I was a kid anyway.
That's a whole thing we could come to the table with at some point, all the superstitions that we either broke or still uphold. Okay, well, wonderful. So Keynote 006, I think you were an author on this. You want to take us through the citation and the work?
Yeah, so Caroline Robert presented this at ESMO 24 in Barcelona, and then the paper is in Annals of Oncology, just out at the time of writing. In fact, I'm not sure it's even got a kind of article number or anything. It's out online anyway. And then Georgina Long is the lead author, and Caroline is the senior author. So pembrolizumab versus ipilimumab for advanced melanoma. Go on.
It has a XXX rating for it's available online. It says XX.
Oh,
is that what yours says? Well, no, it's funny. Instead of having an online, like you're saying, it doesn't even have like an online number, article number. It says available online.
Yeah, you're right.
XXX.
Yeah, I'm looking at that as well. It's XXX rated, so that's just something to watch out for. But younger viewers and listeners. Anyway, so so where I get to 10-year follow-up of the phase 3 Keynote 006 study. So basically, this was the original randomized study of Pembro versus Ipi. Actually, there were 3 arms. So there's 1-to-1-to-1 randomization. So there were 2 different Pembro schedules. One was 10 milligrams per kilogram every 2 weeks, or it could be 10 milligrams per kilogram every 3 weeks, or Ipi. And the Ipi was the standard 3 milligrams per kilogram every 3 weeks for 4 doses. And I was just reading this earlier, and I was just reminding myself of the recruitment time, but it was only open, I think, for around about 6 months. in sort of 2013, 2014. And I remember it all quite well because at the time we were having a real struggle to get access to anti-PD-1 for patients in the clinic. And we already knew by then pretty clearly that this was active. So it was one of those ones where, patients and, everyone in the UK was really desperate to be able to access this for their patients. And so we were able to recruit reasonably well, I think, because of that. And it was around about the same time. I think Checkmate 67 may have recruited slightly before it and then closed, and then Keynote, for us at least in the UK, came afterwards. But it wasn't open for long. You're going to say?
Do you remember the history of this? As you say, it was 3 arms and 2 dosing schedules. This was essentially the confirmatory trial that was required for lambrolizumab, for pembrolizumab, when it first came out in that non-randomized that had a few dosing schedules. This was the phase 3 to follow that up. So as you say, we already knew from Keynote 001 that had granted accelerated approval in 2014 that this drug was active. We knew IPI, we had an approval for IPI. 067 had recruited, I think you're absolutely right, at that point. So we knew the combination. There was a fear for people who'd only use single agent. There was a sort of this, I remember Patrick Hu saying, Mario Snoll tells us, if you get the combination, you have to buy the patients a new toilet, basically. There was this connotation or fear that, boy, the toxicity from doublet was strong. And so this study was actually appeal, because you might wonder, like, why did 006 even have any appeal if we already kind of had a touch point on 067 and 066 and some of these others? But the truth is, this was now going to tell us, was pembro better, or how much, it was going to quantify how much more active it was than IPI, and it was still working out this dosing level and schedule. What the FDA would later come to call Project Optimus. What is the optimal dose and schedule for a drug? This Keynote 006 was doing essentially to confirm an 001 accelerated approval.
Yeah. And I guess the benefit of hindsight, if you kind of work out those pembro doses, we're giving less pembro now than we were at the time. But I mean, maybe a couple of comments. I mean, first of all, both pembro arms looked extremely similar to each other, I think, for efficacy and safety. We know that already. So that's one, and so, I've talked about this before, but to me, that's all about the dose of this drug is seriously topped out by the time you're getting to these kinds of doses. So that's maybe a passing observation. I think maybe the other thing to say about the trial design is there's this business about transitioning to Keynote 587. So that was a kind of mechanism, if you like, for some of the patients to continue to be followed up. And maybe that's worth saying, actually.
Still, that study goes on, right?
Yeah, absolutely. It's a kind of, I don't know, it's a kind of extension follow-up basket. It's not really a basket study, but it's a way of collecting further follow-up data. So, that kind of strategy is pretty commonplace, I would say. But I'll just read out, and this is just from the abstract. Of all the patients in the study, 834 was the total. 333, so that's almost 40%, were eligible for this transition. And about 200 transitioned, 211 out of 333. So there were some that didn't transition. The baseline characteristics of those who transitioned versus those who didn't transition were similar, which is an obvious question you might ask about this. But nevertheless, it's important to note that some of the findings from this, are as a consequence. Some of the data reported are from this kind of follow-up, this follow-up program or trial, if you want to call it that. I mean, to cut straight to the chase, I think what we're seeing here is confirming what we already knew in terms of the benefit of pembro over ipi mono, in terms of PFS, in terms of OS. I think it's very consistent, if that's not an abuse of the word very, with Checkmate 67 for the comparison between ipi and nivolumab. So it all sort of fits together. Maybe one of the other sort of interesting things here is the the people who got second course pembrolizumab. So this I think is worth noting actually, that in this trial 2 years of pembrolizumab was given, and this is actually something I use when I'm talking to patients now, maximum of 2 years of treatment. So to get to 2 years, A, you need to be getting benefit from treatment, B, you need to not have had any bad side effects, and C, you need to want to do it as well. I mean, there might be the odd patient for whatever reason, and there might be some differences here in our practices here actually, where the patient wants to have 2 years of treatment rather than less. Anyway, so you've got these patients that get to 2 years, stop treatment in the trial at 2 years, you carry on following up the patients, and then some of them will progress down the line. Not many actually, and I normally quote about 10-15%, something like that. And then in the trial, you are then allowed to retreat with pembro these people who had progressed. And guess what? Won't come as a big surprise, but many of them got benefit again from second course pembrolizumab. And actually in this paper, the efficacy outcomes for this group of patients who got second course are actually presented. And again, guess what? These patients do extremely well. But this is an extremely highly selected subset of patients who get to 2 years in the first place, brackets, they've got anti-PD-1 sensitive disease, relapse down the line, you give them back the drug back again, and then they re-respond most of the time. And so because of our sort of reimbursement situation, that is a conversation that actually we have with patients quite a lot when you're coming up, or when you're thinking about getting to the 2 year time point. You look like you've thought of millions of questions when I was just talking.
I have so many now. Yeah. So one is this idea of getting to 2 years. Is that what you would do with a patient in CR who gets into CR in their first year? Do you give them 2 years or you stop early?
Yeah, we still tend to, which is, conservative. I think you would say that. I mean, I'm still not,
No, that's fair.
to that. Yeah. To that question though, the whole, CR, getting back to CRs again, at the moment, I'm still not aware that we've got prospective randomized evidence for getting to CR and stopping versus another strategy. But on the other hand, we know these patients do. Yeah, these patients do really well. We know that. They probably don't need much treatment actually in the first place, I would also say. And then we have this whole problem. If you stop a treatment, you lose it. It's gone. So we tend to carry on.
That I understand. If you didn't finish the 2 years and then if you stopped at 1 year because they were in a CR and then you had a recurrence, there would be some sort of issue that you didn't take the full treatment before, therefore we can't reuse it. There'd be some diciness there. I get it. Then my other question becomes, there's a few things. We've got series from Australia and other places that tell you these are the characteristics of long-term people in CR in whom they did not receive 2 years. It's often people who get into a CR quickly, who take more doses on the backside of getting a CR. So they don't get to their first CR or confirmed CR and then drop the treatment. They stack some more treatment behind it, which speaks to the idea of using that treatment to develop memory immune systems. So it's interesting to me that in the neoadjuvant setting, we're willing to sort of stop it right away without giving maybe more to develop that memory immune system. This is all theoretical because we have no blood-based marker to say you've developed memory T cells now against tumor antigen XYZ. So we don't actually know when somebody's developing memory. That's why we can stop in a CR and still recur. How many people get 2 years of treatment in a CR versus PR who then go on to recur? That's a complicated question. What I mean to say is you're at year 3, 4, or 5 with this melanoma patient. You've given them 2 years. They were either a CR or PR. So first of all, what's the breakdown there? How many CRs, how many PRs? And then the second question would be, when you do this re-challenge, have you noticed that it's a specific phenotype? It's the CRs that are getting a second bite. It's the PRs. It's both. And then the third part of that is, what's the durability of that second challenge?
I'm not sure I can answer any of those questions.
As a co-author.
No, I'm not sure I can answer any of those questions very well, because at the end of the day, the numbers were not that big. And then you've got this issue about the Keynote 587 as well. So although the baseline characteristics were matched, there's going to be some selection or ascertainment bias there.
Is it wrong to look at figure 3 and say, just based at the number at risk, to say that there are twice as many PRs as CRs?
What, and imply or impute from that one or other
that was
is
just
kind
part
of
one
better or worse?
No, that was just part one of my question, which was like, what percentage of these people who often do 2 years, because these are the people that rolled over into, or this is all 006. Anyway, I guess what I was, like one of my first questions was, of the people who take 2 years worth of treatments, how many of those are CRs and how many are PRs? Overall, there's twice as many PRs as CRs, but that doesn't necessarily mean that those PRs go on to 2 years, because they could be PRs and then lose their PR, in that 2-year period. Anyway, so maybe we don't know that question. Unless we looked at a 587 curve. If there was a 587 curve in here, maybe we could look at the number at risk.
Yeah, I still think that the basic take home here, it is, guess what? It's better to have a CR than have a PR. It's better to develop it quickly. And those are the patients who probably don't need really much treatment at all. And, I take your point about CR plus, which is totally reminiscent of lymphoma as well. And, you might make a point there that in lymphoma, they actually spend a load of time doing trials. I remember this, to define this stuff. If you go into response, you can stop your R-CHOP. I mean, diffuse large B-cell lymphoma, for example.
I would like to see in the second course, I would have liked to have seen how many of those were CRs with their first course of Pembro, how many were PRs. I would have liked to have seen, because that helps you when you counsel a patient. If they hit CR in their first 2 years, then you can say the chance that you're even going to need a second course is roughly this. I know you said 10 or 15%, I know, but that's everybody. That's everybody who takes 2 years worth of treatment, including potentially some stable disease people in there. It'd be nice to know what that breakdown is of the second course. It would also be nice to know some kinetics about how much they took in their first course. How quickly did they get into a CR? So were they somebody who eked into a CR 22 months into a 24-month induction, first course? Is it people who went quickly and then, for whatever reason lost it? I would like to see this paper had so much potential to do that, I guess is what I'm saying. It's a great paper. I'm so glad we see this data, but it's not exactly helping me in clinic other than to know what I think we already knew with the 7-year data and the 5-year data. People do well.
No, I agree. I mean, no, I think those are all great points, actually. And I mean, this paper's sort of come out in conjunction with ESMO, as it were. And that's what happens with these things. But I think exactly as you say in clinic, because I'm not sure we really know the answer to this question in clinic. How do we counsel patients when you're stopping, other than what we've said already? So that would be useful information. Whether we'll ever see that or not, I'm not sure, actually. But
right. Well, also, isn't there a bigger point here? Like, don't you look at patients and think about, are they recurring in exactly the same spots we had the cancer before, or are they having new tumors? I think by and large, they have new tumors. I think we can agree to that. But wouldn't you like to, there's something about, it's not tempo, it's not, but there's something about that phenotype. So I would have liked to have seen like CR/PR, how quickly they went into a CR/PR, what was the interval to recurrence? Are they somebody who took years to recur? They recurred within a year of stopping. And then what was that pattern of response? They developed new tumors, which might suggest a different mechanism of disease recurrence than if they regrew tumors that were in. Anyway, these are all the things we think about in the clinic room, not just, can I give them another bite of the apple? Okay, it's responding. It's like trying to tease out a little bit more, who is that patient, right?
Yeah, I mean, my experience, for what it's worth in clinic about this, is that it feels very much like the people who are destined, when you stop treatment, to progress. It usually happens relatively quickly. Let's say by 12 to 18 months. And then that feels to me it's an issue that you need, quote unquote, need the drug on board for the disease to be under control. So it feels like the drug's no longer quote unquote on board. That's far too simplistic given how the drug works. Things start growing again, you put them back on treatment, and then usually things will be controlled again a lot of the time. But to your point, I suspect, guess what, there's a lot of complexity here in these different disease patterns and heterogeneity as well, which makes sense if we're talking about this whole thing about existing sites of disease versus new sites of disease. So I don't think it's really come out in this paper or anywhere else, but it would be great to have that in clinic.
Yeah, and I think we were just sort of quickly catching up on, they have a nice figure. I made it small. Let me zoom in. Figure 2, which is a modified PFS from week 94, essentially at the 2-year mark. So what is the progression-free survival from the 2-year mark onwards in the pembro-treated patients? And then they have figure 6, which is what is the PFS from the start of a second round. So for people who needed a second, and by the way, look at these numbers, 16, is that 16 patients?
Yeah.
So we're really talking about data on 16 patients who took a second round versus what is your PFS from the 2-year mark. And because of what you were saying when you first started, 211 of these 333 or so went on to receive a second round. That speaks to some people obviously going on to combination when they have a recurrence. And
yeah, to say the very least. And it's actually exactly the same problem that we talked about a lot, and we talked about at ESMO, about the adjuvant pembro trials. It's exactly the same issue. There's this whole idea that, if you relapse, because if you're in the placebo arm, so it's the same for the Keynote 716 and Keynote 054. And then actually, I showed a slide to this effect at ESMO as well. If you drill down into the number of people who actually got the single agent anti-PD-1 at progression after having placebo for adjuvant, it's a really small subset, very highly selected. And of course, it's an important idea, but who says this is going to be the right treatment for even a majority of patients who are in the clinic? It's not. It's going to be a minority.
Right. Yeah.
So good effort.
Nice.
But
Very good effort. Will we ever see data from 067 or anywhere else about ipi-nivo retreatment? You take an ipi-nivo, it does you well, chased the CR, got it, maybe small fraction after 2 years has a recurrence after 2 years of therapy. Will we ever see any data about retreatment with ipi-nivo?
Well, you couldn't do that in the trial, is the first thing to say. So then the question would be, so that won't exist in the trial CRF, as it were. So then the only way to do that would be as an academic effort, and with the same sorts of issues of people that relapsed, and then the problem there is obviously going to be that depending on where you are in the world, you've got different options, and so there's going to be enormous selection bias. But I would say, and some of this comes back to clinical practice again, if you've been sensitive to these drugs once, there's going to be a really good chance that you're sensitive again down the line, and then you've got a bit of a question about anti-PD-1 versus anti-CTLA-4.
Yeah, so this is, I guess, my question.
Are you responding to? Sorry.
And this is maybe a little call to action to some of your sweet fellows, Zayd, if you're listening, or, Inez Perez de Silva in Australia, if you're listening. Maybe send around one of these global data sheets and say, look, can you systematically, methodically, or, by recall bias, think of any ipi-nivo treated patients that you treated, hopefully up to 2 years, who had a recurrence. Now give us all that data. Like, let's look at what did you do at recurrence, and answer some of the stuff that we just talked about. Where was your disease when you got your first batch of ipi-nivo? How many sites, largest tumor burden, maybe LDH, because we're interested in that as a cursory biomarker. And then when you recurred, was it same or distant sites? What did you use to treat? No judgment, whatever people use. Is it Nivo-Rela? Is it another Nivo-Ipi? Is it a clinical trial? Is it PD-1 mono? Because you think like, they, maybe that's all they need. And then look at what that looks like. I'm curious in those intervals. What are those intervals like between getting an excellent 2-year benefit out of ipi-nivo and then having a recurrence? How fast did they go into? Look. Some very talented fellow understands this question as convoluted as I've just made it and can probably
No, but
steer
the
ahead of it.
numbers would be small in Checkmate 67 because if 314 patients or whatever getting ipi-nivo, okay,
For sure.
get
But
it
in the
to
world since
get
then, there has to be tens of thousands.
yeah, that's also true. But yeah, but if you look at those PFS curves, for example, they're really getting quite flat. So by definition, there won't be that many progression events. So it really would be
Oh,
a
that's your
global
point. Yeah,
effort.
yeah,
Yeah,
yeah. Yeah, yeah,
given the
exactly.
numbers.
But
Yeah, but
if
it's
we think even 30% of these CRPRs, will have some radiographic recurrence or something, or live long enough to have that, I don't know. It'd just be nice to see that on a large global denominator.
yeah, it was true. And I guess the other thing is we deal with this in clinic the whole time, but we have that. I'm not aware of an attempt to try to codify it actually. Yeah, that's a nice thought.
Right. Good.
Is there anything else we need to talk about from this?
We certainly didn't talk
paper? I mean, I would
toxicity here, though I see that it's written very well here. And I mean, it's not written or described other than to say probably no new tox signals emerged, right?
Yeah, I think that's right. I mean, we've talked about it before. There's sort of, a broader question, even with 10 years follow-up, there might be side effects that take longer than that to develop. And, we're only going to find that out sort of at registry level, I think. Or, we talked about survivorship before. So there is that question. But, of all of these trials, there hasn't really been any new toxicity signal from the first report to 10 years. So we can have some confidence about that. I guess, the other thing I was going to say is that this whole 2-year thing, I'm not saying that's the right duration of treatment for everybody,
Right.
because we've talked a little bit about that already, but at least we have a number in the melanoma field in our head. And in kidney cancer, which I treat as well, despite the fact that you've got a similar number of, if not more, registrational studies that have been done in kidney cancer for checkpoint inhibitors, over the last sort of 5-10 years, we still do not have a well-defined duration of treatment with checkpoint inhibitor for metastatic disease in kidney cancer, because the trials weren't done in such a way that you could make sense of them in a way that we are, I think, in the melanoma field, able to make sense of this trial. So, we're still scrabbling around in kidney cancer with this question.
Except you and I probably both remember that one of the early approvals, and maybe we can do a fact check to this episode at some point, one of our early approvals actually had an indefinite duration on its checkpoint, whether it was Nivo or Pembro. My memory tells me it was Pembro a lot of times, but I think somebody at Merck fact checked me on that one diet. And then we looked and maybe it was Nivo. But initially, one of our checkpoint inhibitors said you give this indefinitely. We know it wouldn't have been IPI since there's a finite course of IPI. And that eventually did get modified. So hang on, kidney cancer will come around. Maybe you guys will sort this through in due time.
Yeah, maybe, but I just don't really think the evidence is there at the moment, and that's kind of the point, really. Now it's nivolumab, and when we, in the very early days of nivolumab, so the first trial we did was Checkmate 37 of nivolumab, which was Nivo versus investigator's choice, basically chemo post-IPI. You could give, certainly in the trial, indefinite nivolumab, and actually, I've probably told you this story before, some of the worst, if not the worst, checkpoint inhibitor side effect I've ever seen was someone who had a mucosal melanoma, actually, in Checkmate 37, had been on treatment with nivolumab for years, because we kind of didn't know differently at the time, and just got fulminant colitis out of the blue after 3-4 years. And I'm still scarred by this patient was in hospital for a year, colitis, colectomy, fungal chest infection from immunosuppression. Got him out, and he's still fine now after all of that. In fact, I've spoken to that patient on the phone in the last 12 months or so. And that was what really got me thinking, hang on a second, are we doing the right thing here? And, by then I think we probably had the data from Keynote 006, one of the earlier readouts, and we were able to say, well, look, actually, if you get to 2 years, chances are, and I say this to patients all the time, chances are you're probably not going to ever need any more treatment for melanoma. But it does get back to the points that you made as well.
Mine is, for some reason, I really sit on this 3-year mark, this 3-year spot on the fence, because of back in the IL-2 days, there was a plateau that would happen at 3 years if you were a CR patient. Actually, PRs flattened out at that same place, but I think, PRs were not, maybe just don't feel as good as CRs to high-dose IL-2 to anything. But I don't know. I mean, that doesn't make any sense if they flatten out at the same place. I don't know. It's because you don't have, we didn't have anything else.
I was just going to say, you need to chase CRs, not PRs. We can agree
I know.
that.
Well, that's a cute. Well, you chase PRs in the gym, chase CRs in the oncology clinic, right? So that's
I like
right,
that.
Owen. Right? Chase PRs in the gym. So anyway, so but yeah, so the high-dose IL-2, probably because if I had a recurrence, I didn't know what else to use for them back then. But now we know even like stable disease at 2 years, a lot of that is just like inert tumor. It's just, you can still see it, but they're actually in an actual CR, just radiographically not.
I mean,
anyway.
I think that's worth a quick bit of discussion, actually, because it's highly relevant, to the whole chasing CR thing, because we all know, and we've known for years, that some of these patients who are in what you might call operational CRs, that's one way to think about it, haven't got normal scans, right? And so then how do you disentangle that? Well, it's not always easy to disentangle in clinic, and sometimes the patients really worry about it. Oh, there's this, that, or the other. And I'll say, well, look, the cancer's not active. That's probably some scarring. But no, your scans haven't completely returned to normal.
Oh, I actually want to make another point about this. One of the things we need companies to stop doing is PFS in these long-term follow-ups, right? Because the S in PFS means survival. So you tick on that curve if you've died from other causes. I mean, you tried to make this in your very 4-minute and 59-second presentation at ESMO for 067 that patients are dying of other causes, because you did stay on time. People are dying of other causes, they're not dying of their melanoma. So great, so melanoma specific survival, fine, but PFS really fails me here. What I want to see is TTP. I want to see a time to progression graph, because what I really care about here is has their melanoma progressed, not have they died so much, because what highly selected, I think I'm dealing with the group that's going to have an excellent outcome from their cancer. It's not so much what are they dying of, it's has their cancer progressed, which captures these SD people who are operationally responders, but radiographically just sort of they fall into a RECIST non-response category, but actually their cancer is not progressing. So you would censor people if you lose them to follow-up. You could obviously censor them if they die and you don't know what from. If they die from their melanoma, that's progression. But, otherwise, if they die from something else, you censor them, because what I care about is time to progression. So we don't talk enough about it, but we used to see, growing up in oncology, we used to see a few more things with TTP, time to progression.
Yeah.
And I think for trainees, it was always hard to tease apart what that difference is, but there is a real difference. And when you design a trial with a PFS, I learned this in uveal melanoma the hard way. I should have designed a trial with TTP, because fuck all, I was getting all these people dying of, things that were not related to their uveal, but they were ticking on the curve, like giant cell arteritis or whatever. What I really wanted to make the point is, like, this adjuvant therapy was not causing progression of their cancer. So time to progression would have been. Anyway, soapbox.
But it's a nice point. And, I remember some of this was regulatory back in the day, the PFS being preferred over TTP. But that was the time, when we were talking about different treatments, and we're thinking, it's a different world now. So that's a really nice point, actually.
Yeah, just another graph we could look at. Okay, well, 40 minutes in, one of our longest episodes ever, because there's 10 years worth of data to talk about. Just kidding. Thanks for taking us through this. Congratulations to you and the co-authors for this, because what really should be said here, people move around, people in the companies move around, academics move around. It is actually not that easy to corral this kind of work and data. And so people really have to step up and take the lead when you're looking at, talking to companies, or the companies talking to investigators about, looking at 800 patients here and getting down to brass tacks of who, how do people do at 10 years? Well done. Well done you, and well done everybody.
Thank you.
Okay.